Good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. Today is part of a multi-part series that'll continue into next year, where we're going to look at a potpourri of different prognostication tools. And today, the Karnofsky will be one of our focal points based on our guest's most recent publication. But we're going to look at maybe a few heart failure tools, and depending upon time, maybe we explore some other things as well. So, our guests for today are first, we have Dr. Moritz Blum. He is a clinician and researcher in cardiology at the German Heart Center at Charité in Berlin, Germany, and is a fellow of the prestigious Clinician Scientist Program at the Berlin Institute of Health. Dr. Blum's research is aimed at better understanding the unmet needs of people living with advanced heart failure and developing innovative ways to implement palliative care delivery into heart failure management. Welcome, Moritz.
Very good to be here. Thanks for inviting us.
Absolutely. And second, we've got Dr. Laura Gelfman. She is the Vice Chair, Quality and Clinical Innovation for the Department of Geriatrics and Palliative Medicine at the Mount Sinai Health System and Professor in the Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai. As a clinician scientist with funding from foundations and National Institutes of Health, Dr. Gelfman has examined the patient, caregiver, clinician, and system-level determinants influencing the quality of care for patients with serious illness. Welcome, Laura.
Thanks for having us.
Absolutely. So our format today is going to be kind of a dialogue interview for about 20-ish minutes, give or take, and then we'll open it up for some questions from the audience as well. So I think we start with the obvious. We would love a high-level summary of your retrospective analysis and perhaps some insights into what some of these statistics sort of pragmatically mean for us as clinicians at the bedside.
Sure, happy to talk about that. So I think today we're talking about our paper published in the journal Palliative Medicine earlier this year. And it was a very brief article. It was a research letter, actually. And we did something very simple. We looked at all patients who received palliative care consults at the Mount Sinai Health System within a 3-year time period. That was 10,000 palliative care consults. We had Karnofsky performance status, Australia modified Karnofsky performance status at admission, and we had in-hospital mortality. And what we tried was using KPS, Karnofsky performance status, as a prognostic tool to predict in-hospital mortality. Karnofsky performance status is a scale, right? Scale from 0 to 100. So in order to predict a binary outcome like mortality, we have to use a cutoff. And choosing cutoffs is tricky because you have a trade-off between sensitivity and specificity. Sensitivity being the metric that tells us how many patients who actually die, how many of them are prognosticated as that they will die, so it's a positive test result, and specificity meaning how many patients who don't die are correctly classified as not dying. So those are the statistical metrics that we used, and there's a trade-off between sensitivity and specificity. If you choose a very high cutoff, you will have very high specificity, so you will have not a lot of false positive test results, but you'll miss a lot of the patients who actually will die, and vice versa if you set a very low cutoff. So what we did was a ROC curve analysis. I'm sure many of you have heard about that. I'll just share my screen with our results very quick anyway. Yeah, so this is our ROC curve. We included 10,000 patients who received palliative care consults, and the optimal cutoff that we found was 30 30%. And with this cutoff, we were able to achieve a sensitivity of 71% and a specificity of 78%. But I realize that this is not a high-level summary anymore, and I'm already going into the nitty-gritty. So I'm sorry, I'll stop here, and I'll give it back to you, Martin.
Wonderful. You so we talked a little bit when we were planning this that it would be lovely to anticipate some of the pitfalls of this tool. And I would love to get your thoughts on why certain patients you think with a KPS of 10 or 20 did survive to discharge. Were there any themes?
Um, sure. So I think, generally speaking, just to wrap up the summary, I think our summary would be that the KPS is a pretty decent prognostic tool. It's very easy to obtain. And because you simply classify function, right? How well a patient performs in their whatever setting. That's what the Australia modified KPS does. It's setting agnostic, because the traditional KPS is for outpatient settings, and the Australia modified KPS has a little wording change, so it's already also applicable to inpatients. It's a useful tool. That's what we're trying to say. But obviously, and also the cutoff 30, that's a useful cutoff because people with a KPS lower than 30 are bedbound more than 50% of their day. So it's very easy to ask. You can simply ask a patient, or you can look at a patient, or you could ask a nurse or a caregiver, does the patient spend more than half of the day in bed? It's very easy. That's the strength. But the pitfalls are obviously that it's just a very rough estimator. And there are some groups, like, for example, people who are just because of their disease, like, for example, people with, I don't know, people with leg fractures, they will be in bed more than 50% of the time, potentially, not because they're seriously ill or because they will die, but because of the nature of their disease. So especially in the group of people with neuromuscular disease, neurodegenerative disease, we saw that our cutoff of 30 was not very well calibrated in that population. That would be one pitfall. Maybe Laura, you have more ideas on what to respond to that.
Yeah, I think, I mean, right, and similar, like we were talking about in-hospital mortality, right? So like a similar, like a population of patients with dementia, that might be their sort of prolonged baseline, as opposed to an acute change. So I think one of the things we sort of struggled with is this is looking at their functional status at the time of palliative care consult, right? So we, people who are in an ICU are already, at best 20, because, those that are intubated and sedated, but it might not reflect what they were like 2 weeks before they landed in the hospital, right? And so that we can talk about in sort of future directions, but it is a balance.
Yeah, that's one of the things that struck me too when I was reading your paper. It felt like this tool seems most useful when it's something that is an acute change, not somebody, with cerebral palsy who's already baseline at that, and also somebody that change is due to their illness, not due to intubation, sedation, that sort of thing. So that's really helpful. Moritz, you kind of already touched a little bit on it, but I'll see if there's any more you want to flesh out because um, I mean, I honestly, I've never really used much of the Karnofsky in practice, the original one, because I thought the language just wasn't very user friendly. But you folks, you use the Australia modified. Can you tell us a little bit more about that or anything else you want to share about that?
Sure. So I think I have a slide or two on that. So this slide is essentially just a comparison of the classic KPS, and it uses wording that clearly is not applicable to the hospital setting, but it's because it says hospital admission is necessary. That's not applicable to someone who's already hospitalized, right? And we, therefore, in the hospital setting, we use this AKPS, which is essentially the same except for this little tweak. And I think you're right that seeing this for the first time and trying to memorize this seems like a lot and doesn't seem very intuitive and easy to apply in clinical practice. But there was an algorithm published a couple of years ago that we find very helpful. we first ask ourselves, or the patient, is the patient able to carry on with his or her normal work activity? If yes, then KPS is over 80 for sure. And then depending on the level of symptoms, mild, moderate, or no symptoms, there's more grading. If patients are unable to work, we ask if they're bedridden more than 50% of the time, yes or no. And that's kind of we don't use KPS as a continuous scale. We use it to flesh out certain hallmarks or certain I think hallmarks is a good point. And as soon as you pass those, function is it has deteriorated to a point where it's prognostically significant. Maybe that's what I would say to that.
Yeah.
If I could just add, the other thing that I think that particularly why we selected this is one you guys will notice, for those of you that use the palliative performance scale, there's a considerable overlap, right? It's a very similar structure to the scale. But also I would say is that the hope is, because it's such an easy to use measure, as Morris shows here, that if we could embed it on the patient level, sort of in the EMR across the system, you could sort of track trajectories and sort of trigger clinicians to say, wow, this person was at an 80 and now I'm seeing them at 50, something is different. And obviously there are other ways to tease that out. If someone's coming up with an acute illness, you'll be aware of it. But just the mortality implications of it and the prognostic implications of it.
Lovely. All right, little segue into something new. Other than the KPS, what other prognostication tools have you guys found most clinically useful to you in practice?
Maybe Laura, do you want to answer about your palliative care consult clinical practice? I can talk more about the heart failure context, but I think for general palliative care, you would probably be the person better.
Happy to. I mean, honestly, I think this is because of the ease that anyone can do it, requires little training, and has such valuable data. To me, a functional assessment, a one-item functional assessment, is so critical. Now, if you look at different subpopulations, you'll see different tools, as Moritz referred to, right? There's scale heart failure will come in some, more in heart failure. But if you're looking at most, even, I was just giving a talk to the advanced heart failure group. Like, if you look at a constellation of healthcare utilization, function, and symptom severity, and you sort of look at those three, that is going to be those three together will be really significant prognostic indicators across most disease entities. So healthcare utilization being another one, certainly in heart failure. If somebody's had more than 2 heart failure hospitalizations in the last 6 months, like that is like an opportunity for antenna to go up. And that I think would nicely apply, although it's not done as cleanly in other serious illnesses. But I think intuitively, when in taking care of this population of patients with serious illness across the board, number of hospitalizations is pretty critical, right? If you have advanced cancer and you're in the hospital, that's pretty serious. So I will hand it over to Moritz to share these comparisons.
Yeah, because this is a perfect segue into this study. This was the first study that we ever did when I was still in Berlin. We looked in an advanced heart failure population. We compared the Seattle heart failure model, which is kind of the gold standard, very sophisticated multi-variable model with a lot of variables, blood counts. And we compared that to the number of hospitalizations, which Laura just touched on. And the area under the ROC curve was not significantly different, slightly different, but not too different. And then we combined that with another tool that has been kind of trending in the heart failure field, the surprise question, which is basically a question that taps into clinician intuition, which performs similarly, not so much worse than the multivariate model, even though it's basically costs no resources, no time. You have it simply by asking yourself one intuitive question and the patient one question. And if you combine those, you get pretty decent prognostic performance. A lot of bang for your buck, so to say, compared to the Seattle heart failure model, which is a pain to compute. And maybe more about the heart failure piece of it. Heart failure is it's a roller coaster of a disease course, right? With a lot of decompensations and then recovery and steady state for a long time sometimes, and then it deteriorates suddenly. So it's very hard to prognosticate. There's an acronym that was published in 2017 in the Journal of Heart and Lung Transplantation, I need help, which stands for NYHA class and natriuretic peptides. You can see it on the right. I think if you're interested, you could look it up. The things that I would like to point out that I find very helpful in heart failure is the number of hospitalizations already in there too, right? But end organ dysfunction in heart failure. So if you look at creatinine and bilirubin and liver function, and both those are deranged, that's a red flag in my experience. And the inability of patients to tolerate prognostically important medication due to hypotension most of the time. That's something that is alarming and prognostically relevant. I think that's what I would answer.
So we have these really sophisticated models and they're wonderful, but are people going to use them? And over and over, I keep hearing you saying, let's make this simple. The Karnofsky is so simple. The I need help, some of these smaller triggers, they're more likely to be utilized.
The answer is they have to be simple, else they won't be used. There's a lot of beauty in multivariable models, and maybe they will be applied automatically to electronic health records and computed based on big data automatically, which would be beautiful, right? But as long as we're not there yet, we have to have simple tools because experience shows that the best tool that's super hard to apply won't be used. That's what I think. What do you think, Laura?
Yeah, I think well, predictive analytics is powerful and certainly is it's here already and growing. Various things. Certainly everyone's trying to have their homegrown version of each predictive model. There are a lot of limitations. I have a friend who's building one, and when we looked what are the key variables, for an advanced cancer population, one of the very key variables that the data science folks pulled out was having a thyroid nodule, right? Like that had no clinical significance and no connection to what we were actually trying to look at. And so, you can't have these things sort of in isolation. And I think it's a lot of words of caution of using some of these predictive analytic models and how you actually apply them.
All right, we got one more question, and then after that, we'll open it up to the audience to see if they have anything else for you. So you guys have produced a number of different papers from the same registry. Can you give us a little sneak peek of what might be coming next?
What might be coming next? So the sad thing is, or the beautiful thing is, I was working with Laura for a beautiful year and a half in New York, and we really used the KPS for so many different things. Mostly as for all sorts of things. We used it as a marker, kind of the KPS at the time of palliative care consult. As an indicator of how sick a patient is at the time of palliative care consult. And the fitter a patient is at the time of palliative care consult, the more it could be considered early palliative care. And if a patient is already completely bedridden at the time of consult, we wouldn't necessarily call this early integration of palliative care, right? So we've been using the KPS as a kind of monitoring tool to monitor program performance, for example. So we looked at different departments or different serious illnesses, and we saw we split them into 4 KPS quartiles or 4 categories, and we see that some departments are very good at referring patients early in the disease course. Surprisingly, also cardiology, which is that's because there's a lot of attention to that at Mount Sinai Heart. But we could use that to identify disease groups in which we have to do better with reaching patients early in the disease course. So that's, for example, one possible application of using KPS. And this data set, so that's the beautiful part. The sad part is that I'm back in Berlin now, so and I have a lot of things to do, and I can't work with Laura anymore. So about the future, Laura has to tell you what's up next with the Mount Sinai database and KPS.
Well, I have no doubt that our paths are intertwined forever, Moritz. But I would say the next horizon, we used a lot of this data to prove to the hospital that it was important to have nurses do a KPS assessment at the time of admission. And so, right, we used all this to identify at the time of palliative care consult. Obviously, like at that point, there's had some major decline. It's not necessarily reflective of what these patients looked like before they came into the hospital, right? They may already have developed sepsis and be intubated in the ICU. That's not what they were like prior to coming in. So the nurses now, as part of their admission assessment, document a KPS based on the patient's function prior to their acute decline causing them to be hospitalized. Now, there's some we have to do sort of additional trainings and everything else, but we actually have had pretty great uptick. We had to pause it during COVID, and another mentee is hopefully coming out with some work showing how that is also, how predictive it is of not only inpatient mortality, but length of stay, ICU admission, ICU length of stay, and to just the one thing that was really striking is that while we know it's predictive, functional status is predictive of all those things, yet functional status was not, people at different degrees of functional impairment did not dictate time to palliative care consult, meaning patients who were the most functionally impaired and the patients who were least functionally impaired were all referred to palliative care at a similar time point, like day 6 of hospitalization, day 5. And so that was really striking, that clinicians aren't basically using this as a marker. And so that is an opportunity.
Lovely. Thank you. We'll open it up for questions. If anybody has anything, type something in the chat, use the raise hand function, find a way to get a hold of us in some way, and to give people a moment or two to stew on their question. I've got another follow-up for you. So you guys both have your feet sort of in the cardiology, heart failure, and palliative world to some degree. I think it'd be so wonderful to hear, what do you think are some of the blind spots that palliative care clinicians have towards heart failure? How can we be better, and what don't we know that we don't know? Big smile. So there's something there.
Yeah, you should
Mark,
talk
you
about
want to lead as a resident insider now?
Yeah, so the problem is that at least I think I know a lot about heart failure, so I can't really comment on that too much. I think you have to tell from your perspective from within the palliative care department.
I think the biggest struggle we have is that when we walk into a room of seeing somebody who has end-stage heart failure on inotropes, we're like, oh, this is the end. We need to help prepare them for the dying process. And when a heart failure clinician walks in the room, they're like, okay, we need to start talking about mechanical circulatory support and transplant. And neither is wrong, but we have to sort of have a shared language so that it's a both and. Right? Things can go poorly, and we need to do our best to help prepare patients. Yet these interventions that are now available can tremendously improve quality of life and survival. And, if they're candidates and if they're willing, game to make the lifestyle changes associated with it and all the rest, we would fully support that. And so I think there's just less siloing generally. And I think, and also I would say just we should probably be more, sometimes I wonder about like almost specializing in, like there should be palliative care clinicians who are more specialized in some of these areas because it's so complicated. It's just the same thing with, I don't know, cancer therapies are getting increasingly complicated and it's just it's not one size fits all.
And just to add to that, I think it's not just that the palliative care and the heart failure clinician, neither of them is wrong. They're actually both right. And they have to complement each other. Else bad things will happen both ways. So I totally believe in like cross training and double training. There has actually been a very nice paper published in the Journal of Cardiac Failure recently by Sarah Chusey and I think Sarah Godfrey on pathways, clinical pathways, training pathways for heart failure and palliative care clinicians who want to deal in both. And they also told me in a meeting that when this year, when people applied for heart failure fellowships, a lot of them actually asked about careers in palliative cardiology. So this seems to be something that is coming up, and that makes me very hopeful.
All right. We've got two raised hands. So we'll start with Mark with his first question, and then we'll move to Maureen next.
Yes. Hi. Thanks so much for this dialogue. So this question probably won't come as a surprise from a social worker, but when you were mentioning about the KPS scale and there being certain factors that you had to control for as far as like their condition before coming to the ICU and so forth. It just made me think about what about psychosocial factors? Has your research considered what kinds of psychosocial factors might, for example, I'm not sure if this terminology is used in this context often, but, like in a failure to thrive kind of context where some people's circumstances may also affect whether or not their conditions are going to decline, which is completely separate from, of course, what their actual physical constitutional health may indicate.
Thanks for that comment. This is so great. I'm still in the hospital, and I just admitted a patient with chronic lung disease who has decompensated because her husband had an accident and is in the hospital too, and she's not able to thrive at home anymore. She's experiencing increased dyspnea. She's experiencing like difficulty walking, and it's only because of a shift in her social environment that her functional status has changed. So that's a super important thing to consider, is that psychosocial factors and changes also change functional status. That's something I would be super interested in looking into more in our research. Laura, do you want to take that up too?
I think, one of the benefits certainly in this country of there being an increased incentivization of documenting SDOH will be that we can start to examine that more, right? If you can't pay for your medicines, doesn't matter what we prescribe, right? If you can't have a heart healthy diet and a low salt because it's too expensive, doesn't really matter what we tell you.
All right, Maureen, I think you will finish us up as the last question of the morning.
Psych, it's not Maureen.
Oh,
it's
it's Rose.
Sorry, it's Rose. So as a palliative provider who does subspecialize in advanced heart failure, we're embedded in the team at the institution that I work at. I think, yes, the whole making sure palliative folks know the unpredictability of advanced heart failure, and then partnering with that team to also, kind of to Mark's point, talk about what's actually feasible. So if we're going to offer a VAD, if we're going to offer inotropes, if we're going to offer transplant, is that actually feasible within that patient's life and lifestyle and support system? And if not, then that also guides the palliative discussion. And so really working as an interdisciplinary team is hugely valuable in that realm. So, I mean, I appreciate kind of how the conversation unfolded here, because it really is a large part of how we manage our advanced heart failure patients and kind of see them through that journey of, are they going more towards the end of life, or are we going to be able to have that, you know, going back with an LVAD or a transplant and providing more time and quality?
Thank you. Yeah, that's such an important point, and particularly, right, we shouldn't to help train, I think, often our heart failure colleagues and not offering something that we can't actually do.
Absolutely. And then there's oftentimes some service recovery when that does happen,
Yeah.
which I think then social work and palliative care become really vital.
All right. Thank you guys all for being here. Moritz, Laura, it was an absolute pleasure.
Thanks so much.
All right, guys. Have a wonderful weekend. Take care.